As a major trauma centre, we do see our fair share of traumatic brain injury. So this talk will give an introduction to TBI and its principles of management in critical care. So there are two types of brain injury in TBI. There's primary and secondary. So the primary brain injury we can do nothing about. This is induced by the mechanical force that occurs at the moment of injury. So there's two main mechanisms that cause the primary injury. The first is impact, so that your head hitting the windscreen, or the brain striking the inside of the skull as it moves forwards. And then there's also an acceleration-deceleration injury where the neurons are sheared off by the forces involved. Then secondary is something we can do something about, and this is what the whole idea about neuroprotection and critical care management of TBI is about. Because this is delayed non-mechanical damage influenced by cerebral blood flow, impairment of autoregulation, and cerebral metabolic dysfunction and inadequate cerebral oxygenation. So these are things that we can correct to try and maintain the brain that's viable from getting damaged further. Severity of brain injury is largely based on presenting GCS. A severe brain injury, severe TBI, will be classed as a GCS of 8 or less. Then there's some other sub-classifications as well, but the GCS is the main one we tend to use. And then moderate being a GCS of 9 to 12 and mild being a GCS of 13 to 15. There's lots of different types of brain injury: extradural, subdural, subarachnoid hemorrhages, intraparenchymal hemorrhages, more diffuse cerebral contusions, and diffuse axonal injuries, and we do see all of these things in TREE. So this is an extradural hematoma. You can see this by the shape of the hemorrhage, in that it's convex, it's secured to the suture lines of the skull, and this is caused by arterial bleeding from the meningeal arteries. It's commonly associated with an underlying skull fracture. So if we see an extradural hematoma, we need to think, where is the skull fracture? Because there's usually one associated with it. So it's not as common as the others. It's only 1 to 3% of traumatic brain injuries, and it does carry a reasonable mortality of 15 to 20%. However, there's some thinking amongst the trauma literature that this is not really a brain injury. It's kind of an extraneural injury, in that the brain itself may not be damaged. This is just bleeding outside the dura, compressing the brain. So if you can aggressively evacuate these hematomas, hopefully they will have a good outcome. And they've got this typical kind of lens-like appearance, commonly caused by bleeding from your middle meningeal artery. And the classical presentation is that a patient will have a head injury and then have a lucid period before a catastrophic GCS drop. And they require rapid surgical management to prevent your intracranial pressure rising very quickly. Here we have another common type of hemorrhage. This is the subdural. You can see that because of the concave approach that covers the entire surface of the brain. It's not constrained by any sutures or any dural folds. And again, they can be chronic, they can be acute on chronic, and often the radiologist will give us an idea of this based on the patterns within. So the darker the blood, often the older the blood, whereas acute hemorrhage will look much lighter. They do have very high mortality in trauma, and that's because there's going to be an underlying associated brain injury, because this is bleeding from the bridging veins and is associated with a high-speed deceleration injury. So there's almost always an underlying brain injury. A very big one may need an urgent craniotomy to stand any chance of survival. However, if a patient presents with a GCS of 3 and bilateral fixed blown pupils, then it's very unlikely that they'll be offered surgery, because the outcomes of these with or without surgery are very, very bad. And then traumatic subarachnoid hemorrhages. So again, we see these. The classical subarachnoid hemorrhage we think of is aneurysmal, but they can be traumatic. though we will still need to exclude an aneurysm being present as well. And the blood tends to follow the sulci, so it's in the subarachnoid space, and there may be bleeding into the ventricles as well. Intraparenchymal, so most commonly these are hypertensive bleeds, but they can be traumatic as well. The location within the brain will determine the management. If it's a very deep lesion, very deep hemorrhage, it's unlikely that they'll offer surgery because of the damage associated with getting to it and the poor outcomes regardless of management. And if you're very unlucky, you might end up with all of these things at the same time. Contusions we see quite commonly, they will be on the side of the head where the impact was. Bilateral frontal contusions are very common with a head-on impact. And they can be localized area of swelling and microhemorrhages, and often they tend to get worse before they get better as they swell and continue to bleed for a little while. So while the patient may appear neurologically okay initially, if they have severe contusions on the CT, there is a very good chance they'll deteriorate before they start to improve. Diffuse axonal injury can be difficult to diagnose. If severe, you will see evidence on a CT scan. You see multiple small hemorrhages within the brain, typically at the border of the grey-white matter. And this is because there's been a significant deceleration injury, and the shearing forces has caused these two different types of nerve to shear off from each other. And then that results in diffuse cerebral dysfunction and very poor outcomes. The gold standard in diagnosing this is an MRI. And here we can see an MRI scan of someone with diffuse axonal injury showing widespread loss of grey-white matter, clarity, multiple little punctate hemorrhages. So the assessment of a patient with TBI is similar to the assessment for many different things. It's going to be history, examination, and special investigations. So in particular, the history, we want to know what the mechanism was and the duration of time pre-hospital the patient was injured, because if a patient has had a significant brain injury, has had some associated impact apnea and has laid on their face in a puddle for half an hour, their outcome is going to be worse than someone who has a head injury and comes straight to hospital. Examination must then be performed focusing particularly on GCS, pupils and focal neurology. If a patient's about to be intubated, very important that you examine them and document their pre-intubation neurology, because that often will be the last opportunity to do that. All patients will get a CT on arrival, and then an MRI in an intubated patient at Aintree is logistically harder, but they may need one of those over the following few days too. So early management, it's important in severe traumatic brain injury to control the airway, to avoid hypoxia, to avoid hypotension, to get prompt imaging and prompt decision making. It's worth pointing out that if a patient is hypotensive, it's never going to be because they're bleeding in their head. It's impossible to bleed that much into your skull to cause hemorrhagic shock. So you need to think, where are they bleeding from? Because it's going to be somewhere else. Intracranial pressure. So the normal state of intracranial pressure is that the skull will contain four main components. It will contain the brain, obviously. There'll be some associated cerebrospinal fluid. There'll be some arterial blood and some venous blood. Now, as the volume of brain expands, for example, when there's bleeding in the brain, there's a certain amount of compensation that can occur within the skull where venous blood and CSF gets squeezed out. And this means your ICP will stay constant. But this can only happen to a certain point because the skull is a fixed box and there's only a certain amount of things you can squeeze out of it before you run out of that and the pressure will start to rise. So once you decompensate, the pressure will rise very, very quickly inside the head. And this is represented on this graph. So initially, as intracranial volume increases, your intracranial pressure will stay the same. However, there reaches a point of decompensation where the pressure rise is exponential, and this is very serious. So, intracranial pressure monitoring, there's lots of different ways to do it. The most common way we would do it at Aintree is an intraparenchymal ICP bolt. and the neurosurgeons can come over and put this in on the unit for us. But there's lots of other types that are used, that they tend to be in specialist centres. For example, intraventricular catheters would only really be used at a specialist neurosurgical centre. WHO? Well, NICE guidelines would say that if you have a severe traumatic brain injury and you're unable to either monitor the neurology, for example, if they're intubated, you should have an intracranial pressure monitor. There are other things that might dictate the need for intracranial pressure monitoring. For example, if you come into a high-risk group, so if you're someone that's had a significant brain injury with large amount of contusions that you think is about to swell, but has been intubated for other reasons, so you can't monitor the neurology, there might be a consideration to put one in these patients too. But in all patients with a severe traumatic brain injury, we need to be having a conversation with the neurosurgeons about whether they feel ICP monitoring is indicated. So a lot of what we do on critical care related to traumatic brain injury is related to ICP control. And this is sort of comes under the umbrella term of neuroprotection. So a normal ICP should be about 10 to 15. It's going to be slightly higher in a ventilated patient, but certainly once you get higher than 20 to 22 millimeters of mercury, this would be considered dangerously high. And control of these things here can affect the ICP very quickly, and that becomes very evident when you have an ICP monitoring in place. So hypoxia will cause increased cerebral blood flow, and this will raise your ICP very quickly. CO2, the autoregulation of the blood flow in the brain, is lost in a severe traumatic brain injury. So cerebral blood flow becomes directly related to cerebral vasodilation and vasoconstriction, which is largely controlled by CO2 concentration. So when the CO2 goes high, the ICP will increase very quickly. Positioning, so obviously if the patient's head down, their ICP is going to be higher. If the neck is in an abnormal position, you can very easily flex or kink the internal jugular veins, which will reduce your venous drainage and increase your ICP very quickly. Clots, so if there's a big extradural hematoma or a big subdural hematoma and you're struggling with ICP, it's going to be worth a discussion about whether that needs to come out quite quickly. CSF, so if the patient's got hydrocephalus related to inadequate drainage through all your CSF aqueducts within the ventricles because they're clogged up with blood, then this needs to be treated as a matter of urgency. Similarly, Valsalva, so if the patient's straining, so if they're under-sedated or if they're in pain, this is going to put your ICP up. Because the main reason we're controlling ICP is because we're very interested in the cerebral perfusion pressure, because this is what allows the brain to receive oxygen. Perfusion pressure really is king in neuroprotection, and cerebral perfusion pressure is your mean arterial pressure minus your ICP. And this is what guides our MAP targets in brain injured patients. Because if we imagine that your ICP is 20, the magic number for cerebral perfusion pressure is 60. So to achieve this, we're going to need a MAP of 80, which is why, as a general rule, our target would be 80 for a patient with a traumatic brain injury. The standard therapy that everyone gets with a brain injury is they get intubated and sedated. Now, the amount of sedation that you're going to give them to intubate them is the same as if they're awake, because the brain needs to go to sleep so the brain can be nice and relaxed and the ICP can come down. So even if they're GCS 3 and they've had a severe traumatic brain injury, they still need induction drugs. The goals of sedation will change based on the ICP. Now, if they don't have an ICP monitoring, which they won't at first, then we're going to deeply sedate them down to a RASS score of -4. If it's less, then we might allow them to wake up slightly. If they're straining and coughing and this isn't controlled by sedation, then we'll need to paralyze them. We'll need the head of the bed up by sort of 40 degrees. We don't want anything around the neck that could reduce venous flow. The CO2 is going to be tightly controlled between 4.5 to 5 via the ventilator. We're going to keep their blood sugar normal. We're going to transfuse them to an HB of over 70, and we're going to keep their oxygen normal with SATs of over 94, because the goal really is a cerebral perfusion pressure of 60 to 70, and this is what we hope will reduce secondary brain injury. If we're struggling and the ICP is still high, despite all those tier 1 therapies being in place, there's other things we can try, such as osmotic therapy, for example mannitol or hypertonic saline, surgical decompression, like a decompressive craniectomy to allow the brain to expand outside the skull and therefore reduce the pressure, or a barbiturate coma, so a high dose thiopentone infusion will induce an isoelectric EEG and will reduce your ICP. Decompressive craniectomy is a little bit of a controversial topic because it does show that when you perform it for a raised ICP, it's very effective at reducing that. So if you decompress someone and take off half their skull, their ICP will reduce very quickly and very effectively. But the question is whether or not this is the end point we're interested in, because patients don't really care what their ICP is. They're interested in, are they going to survive? And if they do survive, what state are they going to be in? And in the surgical group, we can see on this, from the Rescue ICP study, that there are less dead people at the end of the trial, so more survivors. But actually, in terms of the number of people with either upper moderate or good recovery, so people who are able to be left at home unattended, may be able to get back to work and care for themselves, the numbers are the same. So actually, what we're doing here is, by doing decompressive craniectomy, is we're probably allowing more people to survive in a worse state that perhaps they wouldn't want to be in. So it's useful data for informing discussions around whether to choose to progress to a decompressive craniectomy or not. Antiepileptics. So if a patient's got a severe traumatic brain injury, particularly bad in the cases of bad contusions, we might consider starting prophylactic Keppra. Now, we don't do this for everybody, but certainly if you've got a depressed skull fracture, extensive contusions or a subdural, we would tend to use prophylactic Keppra. Steroids, there was a vogue for doing this at one point. Essentially, there's no evidence its benefit, and the steroids are actually probably harmful, so we don't give steroids for traumatic brain injury.